This is chapter 16, Assessing the Eyes. The objectives for this chapter are describing the structure and function of the eyes, discussing the risk factors for cataracts and other diagnoses, including macular degeneration and glaucoma. Discussing an accurate nursing history of the eyes and vision, discussing physical assessments of the eyes, and differentiating between normal and abnormal findings of the eyes. We also discuss the tests for the eyes and any older adult considerations. Here are a few pictures of all the different structures. So take note of the location of the pupil and iris, the sclera, the conjunctiva, the palpable fissure, and obviously the inner and outer canthus, as we look at those for symmetry, and the assessing the lid and eyelash. On the inside of the eye, again, looking at the sclera, the retina, the location of the cornea, iris, and lens is going to be important, as well as the assessment of the optic nerve that's in the back of the eye. In the chapter 16, you also assess the lacrimal gland, which we know is the tears that will do a gentle washing of the eye to protect it, keep it moist. So you probably don't ever feel any of these glands, but when they're not working properly, it can be a real problem for your patient. So, thinking about the structure and function of the eyes that you need to be familiar with, here are those things listed for the external structures and the internal structures. We will talk about extraocular muscles as we are assessing the cranial nerves, and we know those cranial nerves 3, 4, and 6 work the extraocular muscles. So as somebody ages, they may have some changes to the eye. Some normal changes for the aging adult is some loss of elasticity, decreased tear production or dry eye, arcus senilis, which will show a picture of that. It's a gray ring around the iris, presbyopia or near vision issues like needing reading glasses, etc., and decreased accommodation. The pupils may be less reactive to light, and this can be a challenge and make it harder to drive at night. Decreased peripheral vision and occasional floaters. Now, if there are sudden changes, that is obviously not age-related. Any sudden changes in vision are pathologic for sure. Now, there's different diagnoses that affect vision fields that we're going to talk about, especially glaucoma, cataracts, macular degeneration, and retinal detachment. Now, the visual fields is what a person sees with one eye, so forward and to the periphery. Light strikes the retina, the optic nerve, and those things are processed. So the pupils have a light reflex, cranial nerve 2, 3, senses the light and makes accommodations with the pupils enlarging and constricting depending on the type of light. So that shining a light directly into the eye is direct light reflex. Having the opposite eye respond to the light shown in that first eye is a consensual or indirect response. Now, accommodation is the eyes focusing on objects as they come forward. So we call this convergence, as a object comes toward the bridge of somebody's nose and the eyes constrict and converge, or focus in the middle. So this is the pupillary reflex and the accommodation. So the expectation is that pupils are equal round, reactive to light and accommodation. That is what PERLA stands for. We darken the room somewhat because as we shine our pen light in somebody's eye, there has to be enough light difference to be able to see the pupils constrict, whether it be brisk or sluggish, etc. And we're assessing cranial nerve 2 and 3, the optic and ocular motor. So again, you need to be familiar with direct response and consensual. You can place a barrier between the eyes, a hand or a card or something, so you can see the difference in the eyes. The abnormal findings for this might be the pupils being in a irregular shape or unequal, one larger than the other. Maybe the response for direct and consensual light is unequal. Or there's no response at all. The pupils are dilated and fixed. That dilated and fixed pupil can be related to some levels of blindness. So, anisocoria, excuse me, are pupils of unequal size. Now, if it's less than a 0.5 millimeter difference, that can be expected. But if it's greater and in bright light compared to dim light, can be related to some trauma there. If it's greater in dim light, there can be some other impacts or reasons why. But it all begins with using your pen light to see the size of the pupil and making sure both pupils are equal round, the same. So when we're talking to our patients about some of these things, what are we going to ask our patients about their vision? Do they have any history of eye problems, surgeries? Do they need glasses or contacts to read? Do they take any medications or eye drops? Any history of glaucoma testing or family history? All those things are important. So, for example, if there's a sudden change or acute change, that can be related to stroke. We know sudden change in vision is a sign of brain issue. Any gradual change, like presbyopia, can be related to aging. But diabetes, hypertension, remember we have vessels in our eyes as well. So those type of things can gradually decrease. But we want to monitor those. If patients have occasional spots or floaters versus constant, we want to be able to note the onset, the pattern as much as possible when we're talking with those type of things. But it's pretty common in people over 40 that they have those floaters. Now, if there's blind spots, for example, in the peripheral vision, this can be a sign of a disease process happening. And so you want to have that being looked at. We look at that increased pressure in the eyes, like glaucoma. The peripheral vision is impacted first. So if there are spasms or pressure, pain, any bleeding or redness to the vision, that can be an issue with the retinal detachment or tear. So that's an emergent situation. So halos and those type of things, peripheral vision, halos, we see that with glaucoma. Now, if your patient has a lot of frequent itching, burning, maybe the eyes are dry, redness, the conjunctiva is red, there's frequent eye infections, things like that, or frequent need for drops, and a lot of that can be related to allergies or allergens that's getting in the eyes. Any throbbing, stabbing pains to the eyes or history, getting a foreign object in the eye. The cornea is very sensitive and can get scratched and have some abrasions. So washing gently any foreign objects is an emergent situation. So any other drainage or pus other than tears can be related to bacterial infections. So it would be important to know if somebody's had frequent issues with their eyes, if they are having recurring things, or some of these other symptoms in their history. So glaucoma, the diagnosis we talked about, is the pressure within the eye, the aqueous humor, damages the optic nerve because it's so much pressure, it's putting pressure on the back. It can be caused by all different kinds of onsets, but inflammation, increased eye pressure, diabetes can also facilitate glaucoma. There's two different types: primary angle, open angle, and acute closure. Primary open angle is the most common chronic increased pressure. So aging, family history, and those type of things can increase the risk. So the open angle is a gradual loss of peripheral vision. That intraocular pressure increases over time. Not necessarily are there any major symptoms. Just when they do the eye pressure test, it's noted to be elevated. It's chronic, but can be preventable with screening, because as the pressure gets high enough, or the optic nerve appears to be getting damaged, that they can start doing drops and things like that. Now, the acute narrow angle closure, the drain for the fluid is blocked. It can be severe headache, blurry vision, eye pain, nausea and vomiting, but it can be severe and significant. Now, macular degeneration is when changes to the macula, it's a small portion of the retina, is impacted vascular-wise. It's a layer of the retina. And so it affects the central vision, which all the activities that you need your central vision for, interacting with people, driving, walking around, things like that can really be scary. So patients may initially have blurred vision, maybe in this, of course, in the center there, and things may seem crooked or off, and eventually will progress. Smoking, family history, hypertension, those are exacerbate this diagnosis. So cataracts is that cloudiness of the lens. So when you're looking through this lens and it's cloudy, everything you see is going to be cloudy, and it can develop slowly. It's common in patients over 65 that lens becomes less flexible and transparent, and increased age, diabetes, alcohol, all those kind of things can precipitate. And you can see some of these pictures down at the bottom. Now we do some vision testing, and you probably had some of this vision testing yourself, the Snellen chart, where we're assessing distant vision acuity. We're standing 20 feet away and we're reading the rows. If somebody is nearsighted, or if they have impaired forward vision, that is considered myopia. So think about this: 20 over 20. The first number is the distance from the chart. The second number is the last full line that can be read. So at 20 feet, I see what other people can see at 20 feet. If at 20 feet, I see what other people can see at 200 feet, that would be considered legal blindness. Now, the Jaeger chart is the near vision acuity. I'm holding this card 14 inches from my eyes. I'm covering one eye and reading the rows one at a time. The normal is 14 out of 14, but if I have impaired near vision, that is presbyopia. Now, a lot of times, if patients have presbyopia, maybe they are using reading glasses to help them read things that are close. And as well as the reading piece, it's decreased accommodation. The eyes have decreased adaptation to what you're reading. Now, the other vision field tests, and one of them is a confrontation test. We're looking at peripheral vision. So you're comparing your peripheral vision with the patient, one eye at a time. And so you are going to stand 2 feet away. You are going to move a finger or an object into the periphery of vision for your patient. And so you and your patient should see the same object in the periphery at the same time. If there's any delay, or if there's a difference in your vision versus the patient's vision, there would be a need for further evaluation. Now, the corneal light reflex, or the Hirschberg test, we're testing extraocular muscle function. So you're holding a pen light 12 inches from the face across the bridge of the nose, shining the light. And then you note the location of the light in each cornea. So we would want them to be symmetric, for the light to shine in the same place in each pupil. Now, if they're shining in different places, we may see that with exotropia, which is an outward turning, or esotropia, which is an inward turning. In the cover and uncover test, we're assessing the extraocular muscle function. So we're looking at the deviation or difference in strength in the eye movement. So we're going to have the patient stare straight ahead, cover one eye, and we observe the uncovered eye for any movement. So if there is malalignment in one eye and you cover the other eye, that the eye that is malaligned may try to compensate and come to the center. So the expectation is that there's no movement in either eye when covering and uncovering, but an abnormal weakness or misalignment can be noticed. So esophoria, exophoria is the weakness. Now, if there's a constant malalignment, no matter whether you cover or uncover, we call that strabismus. If there is a inward turning or outward turning, inward turning is esotropia, outward turning is exotropia. But when you cover up the eye that's not malaligned, you would expect that esotropia or exotropia eye to accommodate and come to the center. It's very interesting how your eyes can possibly compensate. But again, if there is no compensation, the eyes don't move, even when covered and uncovered, that's a constant malalignment and it's strabismus. So the positions test. This is the 6 cardinal fields of gaze. So again, we're testing extraocular muscle function, and this is cranial nerves 3, 4, and 6. We have the client follow the object, so up and down, side to side, and then diagonal. Smooth symmetric movements through 6 fields, no issues, no nystagmus, which is an oscillating through the movement. Is the expected finding. If the muscles are weak, they might shake when the eyes are looking up and down and side to side. We call it oscillating or shaking. Now, if there is a lag or a weakness there, that would be something we want to make note of. So the eyelids and eyelashes themselves, we are looking for the eyes to be able to open and close all the way, and the eyelid to sit at the very top of the iris. You should not see sclera above the iris where the eye is. Now the eyelid should be, or the palpebral fissures, should be symmetric on both sides. If one lid is drooping, as you can kind of see in this picture, that is called a ptosis. P-T-O-S-I-S, the drooping of the upper eyelid. Now here in the inspection, we expect that no white sclera is seen above the iris, and you can see in this picture that the eyes are protruding somewhat in the exophthalmos, and the lid margins are pretty high there, and you see quite a bit of sclera on either side of the palpebral fissure. The enophthalmos is the sunken eye, and you can see in this patient's left eye there how sunken that is. That can be seen with older adults, fat loss, dehydration. The eye becomes more the bone structure becomes more prominent around the eyes. So in this picture, we're looking at the lids, making sure, looking at the lashes and the lids themselves. On the right, this picture, entropion is the inward turning of the lid. Ectropion is the outward turning of the lid. The lid should close easily and meet completely. No redness, swelling, or drainage, or any of those type of things. You can imagine if you can't close your eyes all the way completely, that your eyes can become dry and irritated. So here are some abnormals. That edema, the puffy lids, we see that with congestive heart failure and renal failure. Or this infection to the eyelashes and around the eyelids, that redness and crusting can be caused by staph. There's also different follicle infections. There's styes and chalazions. These are blocked oil glands or bacterial infections around the pores and follicles of the eye. Now, the conjunctiva, the sclera, the lacrimal apparatus, like the pictures we saw earlier, the conjunctiva, or the lining within the eyelids, should be pink, moist, clear, no lesions or swelling. Any redness could be related to conjunctivitis, and any blue coloration could be related to cyanosis, heart and lung issues, or hypoxia. The sclera should be white, but if the sclera is yellow, we see that with jaundice. If there's any redness or busted blood vessels, that can be related to some type of injury or subconjunctival hemorrhage, things like that. A blood vessel broke, essentially. Your lacrimal apparatus, typically just non-palpable, should not be painful, or not be able to feel any crepitus in that area. Any redness, swelling, inflammation, or pain are abnormal findings. So here are some pictures of these specific abnormal diagnoses. So the cornea and lens. So we should be able to shine the light on the side of the eye to make sure the cornea is smooth and transparent from the side view. An abnormal finding would be a scratch. You can see in this picture, there's a little scratch or abrasion. That cornea is that outer layer of the eye. Any abrasion or injury will impact the vision through the cornea, right? So the lens should be free from opacities, but in the bottom picture here, this arcus senilis is a variation. It's a gray lining or ring around the iris. And so just a normal variation for older adults. Now, if there's opacities of the lens, like cataracts, that's absolutely an abnormal finding. So here are some pictures of the iris and the pupil. The iris should be normal, round, flat, evenly colored. If there's an irregular shape of the iris, that might be abnormal finding, especially if they are different from one eye to the other. Inspecting the shape and size of the pupil, we talked about that earlier, the anisocoria, and if there's greater than 0.5 millimeter difference in comparing the pupils, you would want to note that. The measuring the pupils against the gauge, you have your pen light that has the different pupils, but we measure those in millimeters. The average is 3 to 5 millimeters, but you may have some abnormal findings like pinpoint pupils or dilated and fixed pupils like we talked about earlier. So the eye assessment or trauma. So if your patient has a sudden onset of something in the eye or severe pain, we're going to observe for foreign body, especially if they were around something or something splashed in the eye. We want to do gentle eye washing, but if it doesn't work and there's blood in the eye, this is an emergent situation and your patient needs to go to the emergency room. Now, if there's any blunt eye trauma, if somebody, for whatever reason, got hit in the face, and when their vision they see is red, that typically indicates some blood in the anterior chamber, and that is an emergent finding. Now, if there's pressure in the eye or the retina is being detached, etc., Um, the pupils are going to change in how they respond, possibly. So, but these are emergent findings because the eyes are very sensitive and somebody could lose their vision. So here's a picture of the retinal detachment. The retinal is lifted or pulled from its normal position, and this could cause permanent vision loss. So some of the risk factors are age and just being sensitive, the eyes being more sensitive. If there's a sudden or gradual increase in floaters, flashes, the shadows or diminished vision, this is worth going and getting this checked out. They have to go and do laser surgery to try to put the retina back in place and repair these tears, and it could take quite a bit. So the sooner that you address these things, the better. So in summary, you need to know the external and internal structures of the eye. How are you distinguishing those uh, um, diagnosis of glaucoma, macular degeneration, and cataracts? What are the tests to evaluate vision? How are you evaluating extraocular muscle function? And what are some older adult considerations you might want to know about? Do you know the expected findings for the structures in the eye? And what are the procedure abnormal findings in assessing the pupillary reaction to light?